My name is Tonia Poteat. I've been super excited to be working with Yi over the course of the last several weeks. And am I the last? Maybe one more week. Okay, I'm the penultimate speaker for today. I got a little peek into the kinds of things that you've had people talk about before. So this might be very similar or very different. I'm also pretty laid back. So if at any point you have a question or a comment or want to have a conversation, I'd much rather talk to you than make slides at you. So please engage with me. We good? Okay. Some of you are like, okay, all right. So I always start with a land acknowledgement. We're on the land of the Tonia Nation, unceded territory. Like most universities, this Duke and UNC, where I used to work, are all built by enslaved labor, and I just want to acknowledge that we are here using that land and that space. I want to spend the next 45 minutes or so talking about the things listed here, starting with terminology, population size, some key concepts that really shape what was about my work, and then go into what we know about inequities related to gender and race and HIV, what we think are driving those inequities, and then some of the research that's happening in my lab. We're good? Okay. And I will say, lab is used not in the test tube way, but in the group of people way. I think they call it a dry lab versus a wet lab, which I'm very grateful for because we are dry in my lab. We're not being rained on. All right, so I'm going to start with something that is commonly misunderstood. So people commonly misunderstand race to be a biological factor, and I'm going to be talking about racial inequities, and it's really important to me that we all start on the same page about that. There's an amazing professor here, Dr. Charmaine Royale, or Royal, I think that's how she pronounces her last name, who's in African American Studies, Biology, International Health, and another professorship, who teaches a great class on this. But I just like to remind people that there is no genetic basis for the concept of race. There's actually not a consistent definition of race from place to place. So in the US, I'm considered Black or African American. When I'm in Senegal, I'm considered clear. And when I'm in South Africa, I'm considered color. I'm still the same person with the same biology. So it is a social construct, and it has lots of serious material consequences because of the way that human beings have categorized race and then tiered people based on those racial categories, but it does not have a biological basis. You good? All right. The next thing I want to remind people about is I'm going to be talking about a lot about gender diversity, and this is a huge debate. There are even people legislating what could be considered sex and gender these days, which I think is hysterical, because if it was so biological and innate, then why would you need to make a law about it? It is not. There is lots of diversity in what we consider to be sex. There are not just two categories. And I have described here, there's at least 5 different components of what we call sex. There's the genetic component, chromosomes, and things like that. There's the gonadal sex, where you have testes or ovaries or a combination. There is hormonal sex, so estrogen, testosterone, progesterone, all of those things. There's internal reproductive organs, and there's external reproductive organs. All of those things can be in many different combinations that create way more than 2 different ways of having a sex body. You okay? Okay, nobody looks hurt, so we're good. We do, as a society, generally categorize the 2 most common ways that those 2 things appear, and then we call it sex, and then we say that we're binary, and then we believe it, and then we create a society around that, which has its benefits for convenience and also has some challenges that I will talk about. All right, this is my next to last orienting slide. I want to talk about gender terminology because I'll be using a lot of these words. Many of you may be familiar with these words. Ashley Florence is a philosopher who came up with the term gender modalities, which I really love, because an identity is something that you call yourself, and a modality is different ways of being, right? So in terms of gender modalities, there's basically states. There's transgender, meaning someone's gender identity is different from what they were assigned when they were born, usually on their birth certificate. There's cisgender, which means that they're the same. And then there's gender non-binary, agender, all those people who fall outside of those 2 categories. You good? Yes. Can you tell me the difference between gender? Yes. Thank you for asking that question. So the way we typically think about it, sex is biological, right? Just sort of like our hormones, chromosomes, body parts, those kind of things. Gender is more social, right? So one part of gender is gender identity, whether I call myself a girl or a boy or a man or a woman, and some of it is social roles. You know, we have a lot of roles in different societies about what women are expected to do and what men are expected to do, and that's all sort of under the umbrella of gender. Does that make sense? Yeah, okay, cool. And then within those constructs of gender modality. This graphic is from Wilson and has some great terminology related to gender. There's sex defined at birth, which I talked about earlier, is what just put on your birth certificate. Baby comes out, somebody looks between the babies like, oh, boy, girl, or we don't know, and we're gonna have Christ. Right. I work on my Hebrew, I'm not kidding. Gender expression is how people dress, do their hair, whatever, to express their gender to other people. I wear a skirt today, so you also know it's girl, woman, yay, gender expression. Gender attribution is how it's perceived by other people. So how you are displaying your gender is one thing, how other people think your gender is a completely different thing often. And then gender identity is how one sees itself. We good? All right. And the last one is about gender diversity. So in the upper right-hand side are a series of a bunch of different gender identity terms. And that's why I say gender is sort of a broad umbrella and gender identity is a key for that. People have lots of different ways that they describe their gender. And I think it's like super awesome and exciting, actually. And I find that people are constantly coming up with ways to express how they feel that their gender is. And I think that's a beautiful thing about being human and about being able to be creative in that way and better describe and be more precise. Y'all are statisticians, you like precision, right? Be more precise about how you want to explain who you are to the world. On the left-hand side is some data that we have on the proportion of populations that are what I would call under the transgender umbrella, right? So this top left study was done in 27 different countries, and they asked people about their gender identity. And about 2% of people around the world in these 27 countries did not identify as male or female. In the US, the most recent estimate from the Household Pulse Survey is that about 2% of the US population identifies as transgender or gender diverse. As I mentioned before, countless gender identities exist, and I think what's often interesting to people around race is if you look at the bottom right, these are data taken from the Williams Institute. There is a higher proportion than in the general population of transgender and gender diverse people who identify as Black or Latino. Latino, Latinx, Latine, all the words. Okay. We good? You done being oriented? The last orienting slide is I'm going to talk about health equity and what is that? People probably have heard about health disparities or just differences in health outcomes. So what is health equity? This is a definition from the Centers for Disease Control and Prevention. So I'll give you a moment to read it. You can see I've highlighted the parts that are critical in thinking about equity. Okay, good. Some people are like looking at me when you're done. All right, so I'm going to be talking about the social positions and social determined circumstances that lead to health inequity. All right, we ready? Any questions, comments, disagreements, arguments, balloons, anything for, no, we're good. All right. So what do we know about HIV among transgender and gender diverse people? This is the most recent global meta-analysis that I've seen published in the literature that looked at data from 2000 to 2019. They divided populations between trans feminine or trans women and trans masculine or trans men. Unfortunately, none of the studies have data on non-binary people or other gender diverse people, so that's what we have right now. They looked at 98 published studies that included 48,000 people from 34 countries. For trans women, and over 6,000 people from 5 countries among trans men. So you can see there's not a balance in the research that's been done, but that's what's out there. And if you look at trans women or trans feminine people, you can see the prevalence of HIV is almost 1 in 5 in all the countries, maybe 20%. And the odds ratio, when you compare transgender women to the general population, is a 66-fold increased odds, right? So enormous inequity there. If you look at trans masculine folks, you can see the prevalence is about 2.6%, odds ratio almost 7. Unfortunately, there are no data from the Middle East, North Africa, or Sub-Saharan Africa among trans men or trans masculine folks. And it wasn't until 2012 that we had data from those regions for trans women. So we're still catching up in terms of global representation. But this is what we know so far. If you look at data specifically in the US, we see, just as we saw globally, disparities by gender identity, with transgender women bearing the heaviest burden of HIV compared to other populations. And if you look on the right, you see the breakdown by race, Black trans women and Black trans men bearing the heaviest burden of HIV. If you've had other epidemiology presentations on HIV, you probably know there's a heavier burden of HIV among Blacks in the US compared to other populations. Yeah. And that's why I always start with that slide about not biology, right? Social circumstance. Yeah.
Sorry, just to clarify on the second graph, what does the y-axis represent?
Oh, the y-axis represents percentage of people living with HIV. Good. I did not label my axes, I'm very bad.
Yeah, I just because it seems like very high. Is that just because there's more data through it?
No, it's just very high. Yeah, I will say these are taken from systematic reviews and meta-analysis, right? And those are biased because they're not population representative. They just take all the studies that are usually convenient samples.
Yeah. Sorry, I'm not the clarification. So in the previous slide, you said that you don't have data for trans up to MENA and from what I recall, correct me if I'm wrong, but HIV is now more prevalent in African countries. Initially, it started, it was more of an endemic, or not endemic, I forget the word for it. It was more prevalent in the States. So does that factor against data for trans men? And that's where it's more prevalent now. We don't have something that's
so many answers to that question. No, that's okay. I would say that it's more accurate to say that there wasn't research done there, but I wouldn't say that there was less HIV. Yeah, so I think the gap is in the research, but not in the prevalence of HIV.
okay.
Is that fair? Did that answer your question? Okay. If not, let me know.
Sorry.
Yeah, of course. Please.
On the graph, so you have the US population. This is like the old graph is talking about HIV among transgender in the US. So the US is the entire population, right? Is that correct?
I'm not sure what you mean.
Like the graph for the US population.
Oh, here.
That
Yes.
represents the entire population.
Yes, that's from CDC surveillance data.
So from there, that's where we have the gender, the non-binary, transgender men,
I see what you're asking.
Yeah.
I think. Yeah, so this US population, so I created these obviously, right? Because they're so fancy. So I took the data from the US population, which is about 0.3% of the US population is living with HIV.
Okay.
And then I looked at the one study that was self-reported HIV for gender non-binary people, and it's about the same, a little bit higher, 0.4%. I put that there. And then I used the data from the systematic review and put that data here. So yes, I'm not comparing all from one study. Oh, thank you for asking that. I love keen eyes. Yeah. Other questions, thoughts, comments? No, we're good. So my point is made, right? Like lots more HIV among transgender people disproportionately. This is data on new HIV diagnosis that was published in the most recent CDC supplemental report on HIV. This is all from the same data, CDC. And I think this is a medical monitoring project that they keep this data from. And you can see in their very very oddly presented graph. It took me looking at this for a long time to understand what's happening. This is cisgender men, this is cisgender women, trans women, trans men, and people with other gender identities. And then how high it is the number of people who are newly diagnosed. And then the arrow pointing is how much is decreased or increased, right? Not obvious. So if you look at the years between 2017 and 2021, new cases of HIV have fallen by 7% among cisgender men, fallen by 10% among cisgender women, increased 24% among transgender women, increased 75% among transgender men, and increased 144% among people with additional gender identities. So we're continuing to see not just a cross-sectional prevalence disparity, but also increasing number disparity. Yeah.
So what category is the additional gender identity? What does it mean?
So they say it includes bigender, genderqueer, and two-spirit. So when they send out when they do their survey, they ask for their check a box. And those are their options. And they didn't pick trans woman or trans man. They picked one of these other boxes.
What are they? Two-spirit?
Oh, well, that's a whole other conversation. I'll do my best for something I'm not an expert in. But my understanding is that two-spirit is a Native American term that is used as a broad term that sometimes is used to describe sexual orientation and sometimes used to describe gender and sometimes a combination of it. And if somebody has a better definition than me, please use it now. Okay. We good? All right. We also see the same inequities by race in transgender people that we see in general. So there's no surprises here. We can spend time staring at it if you'd like, but it's what we expect. Black and Latino transgender women, highest proportion of new diagnosis. We see less disparity with a higher 32% white, but 39%, 25% Black and Hispanic or Latino, respectively, among transgender men, similar among people with additional gender. These are, again, new diagnoses. And if people are living with HIV, one of the goals we have is for people to achieve a co-virus suppression or an undetectable viral load. I'll talk about that. Great. So the Health Resources Administration and the CDC both monitor people's viral suppression, and this is from the CDC data set. And the goal overall is 95% of people living with HIV to have an undetectable viral load, right? We're not there. Admittedly, the most recent data was from 2022, so hopefully things are looking better now. But you can see, if we look among the transgender participants, the lowest receipt of HIV care and the lowest level of virus suppression is among transgender women. But nobody's gotten there yet. And I will say, if you look at cisgender people, they haven't gotten there yet either.
I'm just really curious, where are the two states that don't? It says 48 states.
I'm pretty sure that these are the 48 continental states. Yeah.
Let's
I mean, let's
go.
Feel like it's not important.
Yeah.
I think it's continental.
Okay, all right.
Sorry.
No.
Don't worry, I'll get political later. If I have to fit already. Yeah, so as we see here, the goal is 95%. This is data from the Health Resources Services Administration. It's just the weirdest title. Anyway, they're the people who administer the Ryan White program, and the Ryan White program provides HIV services for people who are uncovered by insurance. They're the largest provider of HIV care in the United States and have, what is it, like 350, 400,000 people receive their care and then therefore have data reported to HRSA on their status of their HIV. So among this population of people living with HIV, you can see viral suppression rates are almost 90% for cisgender men, almost 90% for cisgender women, and about 85% for transgender participants. I feel like this is my last meeting today, of course. Just very slide, I promise. This slide is to remind me to tell you that this has been persistent over time, right? You can see the data started 2010, we go to 2021, even as rates of viral suppression or goals go up for every population, transgender people are not catching up. They're not raising it. They're not achieving viral suppression at the faster rate they would need to achieve equity. All right. So that's it for prevalent stuff. We're going to move into PrEP. So, y'all remember what PrEP is? Who wants to tell me what PrEP is? Yes.
It stands for pre-exposure prophylaxis.
Excellent.
So, a drug or combination of drugs that you take that if your system moves from HIV, it neutralizes the infection of the body by HIV so that you contract.
Yes. Nice. So, prevents you from getting HIV. That is the goal. Yes.
That's a better way of saying it.
I just summarized what you already said with way more detail, so it's good. It's all good. So, for people who are disproportionately impacted by HIV, one of the goals of public health is to make sure folks who could benefit from PrEP get it, right? And as we already saw, the data indicate that there are lots of transgender people who would benefit from PrEP to prevent getting HIV. So what do we know about engagement in what's called the PrEP continuum among transgender people? This is a study that was done with about 1,800 trans men in the U.S. We saw that about a quarter of them, based on their answers to survey questions, would have benefited from PrEP. So 439 people, 24.3%. You can see the questions that they used to determine whether or not they would benefit from PrEP. Then on the right-hand side, you can see what actually happened in terms of those folks' engagement, right? So if you take all the people who would be eligible, the 439 people, more than 100%, 82% of them have seen a healthcare provider in the past year, right? 65% of them have had an HIV test, so you're missing the mark a little bit there. You got to know if they live with HIV, know if they're eligible for PrEP or if they need treatment. That testing happens for 65% of people. And then of those people, 34% of them, so less than half, or a little more than half actually, were given information from their healthcare provider about PrEP, right? And then only 11% actually ended up being on PrEP. So we're not doing a great job. Even people get health care of making sure that they get tested and making sure that they are offered PrEP. So that's where we see the gap for trans men. For trans women, like every other data set, we have more data. This is taken from a longitudinal cohort of about, this is a study I was a part of, about 1,500 transgender women. This is the baseline data. These are the people who were indicated for PrEP, meaning they answered all the questions suggesting they would benefit from PrEP. 83% of them knew about PrEP, so awareness wasn't a problem. But then you see this big drop with ever taking it, currently using it, and being adherent to it. Right? So awareness isn't where a problem is, getting it to people is where the problem is. The second problem is once people are on it, do they stay on it when they need it? Because one of the things people have raised is like, well, suppose you don't always need PrEP, right? Like suppose maybe you have, condomless sex with partners who may or may not be living with HIV, or you don't know their HIV status. And then I'm your person, you both get tested or monogamous with one another. Then you don't really need PrEP. So why are you even on it, right? So whether or not somebody is on PrEP is not the most precise measure of whether people who could benefit from it are taking it. Fair? Okay. So Erin Cooney, who's an awesome graduate student, did this amazing study where she looked at the cohort over 18 months, and she broke them into 5 different groups. And let's see, the red line, that was red to y'all, right? Okay, I was like, red is PrEP indication, meaning people are reporting that they're engaging in behaviors that could put them at risk for HIV, right? And there's 5 different trajectories. Some people could have benefited from PrEP the whole time, the whole 18 months. That's group 1. Group 2 were people who were engaging in behaviors that would benefit from PrEP that decrease over time. Other people engaged in HIV behaviors that beginning and increase over time, like here. You good? And then she looked at whether or not they were actually taking PrEP. So the largest category, unfortunately, is people who were engaging in behaviors that would expose them to HIV and never took PrEP. That was most people. So we have a gap there. The other one that we didn't like to see is people who were engaging in behaviors that would benefit from PrEP. Even though it decreased over time, at no point were they ever taking PrEP. What we really wanted to see were the ones I circled in green here, where people who were engaging in behaviors that would benefit from PrEP, taking PrEP the whole time, people who began engaging in behaviors that would expose them to HIV started taking PrEP at the same time that their behaviors increased, and the people who stopped engaging in HIV risk behaviors stopped taking PrEP and they no longer need it. So those are the three things that we'd like to see. Unfortunately, what we mostly saw is no PrEP at all, ongoing HIV risk. Does that make sense? Okay. All right. This is to remind me to tell you that there's a lot that healthcare providers can do. This is data that's taken from the CDC, that's the same CDC data that I was describing before, divides people by trans people, cis men, and cis women, and you can see awareness is high among trans people. They know about PrEP. And PrEP use is high when you compare to cisgender people, right? But that's among people who were referred. And what you see is that providers were less likely to refer transgender people for PrEP. So there's something healthcare providers can do. We see a similar sort of story if we look at Kaiser Permanente data from Northern California. They have some of the best data, if you ever get to work with their data. So they tracked transgender people who were linked to PrEP, prescribed PrEP, initiated PrEP, and stayed on PrEP, right? And you can see that if you looked at all the people who were linked to PrEP, 69% of them overall, and they have it divided by gender, modality, were actually prescribed PrEP. So not different from what we've seen before. Among those, 64% initiated PrEP, pretty good, but half persisted on PrEP. And the average time that people stayed on PrEP was less than 9 months. So you saw over the 18 months, a lot of people continue to engage in risk behaviors that could benefit from PrEP. Yes.
For the persistent on PrEP, if they dropped off and then got back on, they ended when they dropped off?
That is a good question. I think so, because it had to be sort of continuous over time. Okay. And I don't know, actually, if they looked at if people's behavior changed, and that's why they desisted. But I suspect based on what we saw here, that that's not what was happening. You okay? So why? Right? I've given you a whole bunch of bad news, and what is the reason? And this is why I'm a social science researcher. There's something called social determinants of health. Have people heard this term before? Yeah. This is taken from HHS, the Health and Human Services, and they define basically social determinants of health as where you live, work, and play. And I would say where you live, work, and play is actually determined by policies that are not your personal decision, right? When you're an adult, maybe you can decide within the constraints where you live, but I might want to live in a palace. I don't make palace living money, right? So where you live, work, and play is constrained by the kind of economy that you live in, right? By the level of education you can attain, which is determined by how much money you have or scholarships are available. But just say, like, these are called social determinants of health, but above those social determinants are other structures. Our economic system, our political system, our legal system that constrain those social circumstances that we live in that then determine our health. We good? You okay? Is your place? Okay. All right. So what is the environment that trans people in the US are living in? If you're awake and alive and ever listen to the news, you are probably aware that there is a slew of legislation that is seeking to restrict the rights and opportunities of transgender people. So not moving to protect, but moving to restrict. And the American Civil Liberties Union is tracking 527 anti-lesbian, gay, bisexual, trans, queer bills in the US. for this year. If you looked at the prior year, it was over 400. The year before that, it was over 60. Right? So the legislatures are busy, not making sure we have jobs, not making sure you have enough food. They're making sure that people use a bathroom that corresponds to their birth certificate, that people don't get to play on sports teams unless it matches their birth certificate, and defining sex for us. That's what they're doing. 527 bills strong. So that's what the ACLU is tracking, what these bills are doing. You can see that a lot of these bills are happening in the U.S. South, which is not shocking. If we look at a tally by the Movement Advancement Project, they have a whole sequence of criteria that they use to determine whether states protect you. I think they have high protection, medium protection, fair, low, and negative. Red is negative. What do you notice on that map on the right? Where's all the red? Southeast. Yeah. So the Southeast has some of the lowest sort of positive policy tallies for transgender people in the country, right? So these laws are part of it, but other existing lack of protections and pre-existing laws before we saw this increase in restrictions on access here. So not the greatest political environment. And I will say, I don't have a slide on this, but some of what happens with this policy environment is the actual restriction itself. The other thing that happens is you wake up every day and on the news is somebody saying that you shouldn't exist. What does that feel like? Part of the work that I do, and I'm going to present some of that, is looking at the kinds of toll that this kind of societal stigma takes on the physical body. It's not just like, I feel bad, but I feel bad. It's your cortisol level, it raises your blood pressure, it affects your endocrine function. All of those things happen as a result of waking up every day to your 527th bill, trying to restrict your access to the same freedoms that other people have. I did want to put that out there, that this policy has this social determinant effect, but also has physiological effects. All right, so they're also really busy trying to restrict diversity, equity, and inclusion efforts, and what they call critical race theory, which I think is hysterical. Like, has anybody ever taken a critical race theory class? Really not. Yeah. So it's like an actual theory, right? Nobody's teaching anybody's theory to kindergarteners. You're being like, these are your ABCs, this is history, right? So what they're really trying to restrict is access to accurate American history that includes how Black people have been treated in the U.S. Basically, that's what the critical race theory laws are about. And the DEI legislation is trying to prevent efforts to seek equity related to race, right? So you can see here, there are lots of states that have introduced anti-DEI legislation across the U.S., and a lot that have introduced anti-CRT or critical race theory legislation across the U.S. So you're a Black trans woman in the United States. Are you getting any positive messages? Not so much, right? Then you go to try to get health care, right? So these are data from the U.S. Trans Survey. They did one in 2015, included about 10,000 transgender people, and then one in 2022 that was almost 100,000 transgender people. And they asked people about their experiences with seeking care. They asked about whether they were refused care, spoken to with harsh language, misgendered, or even physically abused. And you can see in 2015, 33% reported at least one of these negative experiences, and then, did I say 2015? I missed that. And then 2022, 48%. So things are not getting better, even in the healthcare setting. So this, the culminating slide, is the social determinants of health, right? So it's just within this atmosphere that people experience economic instability, right? High rates of unemployment because of employment discrimination, people living in poverty because of that, housing discrimination, and high rates of homelessness, bullying in schools, food insecurity, discrimination in restrooms and stores, and all those things they're legislating, and lack of access to healthcare. And all of that affects the well-being of transgender people. And this kind of walks you through it in a less wordy way. And this slide I borrowed from my friend Dr. Asa Raddick, who runs a community health center in New York. So if we start with this, all of this kind of ways of discriminating, these social determinants of health. Discrimination in jobs, housing and healthcare, the effects on the psyche, stress and depression, difficulty getting identity documents that match your gender identity, insurance policies that exclude getting the kind of care that you need. All of that leads to an increased risk environment, higher rates of substance use, higher rates of unsafe sex, and all of that leads to HIV inequities. Does that make sense? This is another more complex model that's been tested over time that was created by Dr. J. Sebelius now at Columbia. And they call all of those things that we talked about stigma, right? And y'all had a talk about stigma? Did I make that up? Yes. I don't need to go through that. So stigma leads to the social oppression that we've talked about, decreased access to having being affirmed in the gender identity that you have, leads to psychological distress that we've often talked about, which increases your need for that affirmation, and it's that gap that leads to higher context and higher behavior, and also some data on lower engagement in HIV care environments. So that's all bad news. What can we do about it? I can tell you what we try to do about it in our lab. Part of which is understand it, and part of which is intervene in relationship to it. So I have a little bit of data on 3 different studies. We don't have time to get through all 3 studies, then I will share the slides, or you email me and get coffee, whatever. But are we good? Do we have questions about anything I've talked about so far? Okay. All right. So the first thing I think is important to do is to start with a strong foundation. The most important thing is to connect communities of trans people and understand what their needs are. I think one of the biggest mistakes that researchers have made is to look at epidemiological data or look at this data and be like, okay, so what we need to do is this, and then go do it without any engagement with the community about what are they already doing, what do they want to be done, how can our expertise as statisticians or social scientists facilitate that. Then collect the kind of data that the community wants and needs, and then use that data for action. So those are the 3 pillars that we try to use in the lab where I work. With community engagement as the base, we do have a network of researchers, clinicians, and trans people who are interested in the health and well-being of trans people that we call the Trans Network on Facebook. Anybody else is still on Facebook? And we have a listserv where we really engage with each other around what does the community want and need. Part of what grew out of that, as well as some local activism, was a study that we call Transforming New Carolina. And that was a study that is basically a needs assessment. We asked trans people in North Carolina and South Carolina, what are your priorities? What do you want in your life? And then thought about what we as researchers could do. So we literally had people write in their top 5, and then we had them select among 5 that we had pre-programmed into Qualtrics. Shockingly, nobody prioritized HIV. And if you think about it, when you're worried about housing, when you're worried about legislative attacks, when you're worried about jobs, HIV doesn't tend to rise to the top of people's concerns in terms of HIV prevention, at least. What were people's priorities were things that make sense to me, right? Preventing violence, harassment, and bullying, access to safe and affordable housing. Those are the top 2. The bottom 3 were access to gender affirmation, right? So getting gender-related care, getting insurance coverage for that gender-related care, and make it easier to change name and identity documents. So that's what we try to do in our lab. So we call our self-derived lab because we're not very creative, and I have to put the students to come up with a name. This research and sexual and gender minority health equity, and these are the icons or the logos for most of the studies that we're working on, and I'm going to talk about 3 of them. So before I dive into those, questions, comments, thoughts, feedback. No, you still with me? Yes.
How long have you been at Duke? I know this is
Duke a year. Oh, okay. Yeah. I was not here before. I was other. Okay. I can tell you my whole story. You're like, no, please don't. All right. I'm going to start with started a study called the IAM study because it's an HIV prevention study. I tried to do an HIV prevention, an HIV care, and then an international. So it is sponsored by the HIV Prevention and Trials Network, which funds a lot of large international trials. And the protocol chairs are myself and Barry Reisner, who is a researcher who's currently at University of Michigan. And the goal of the study was to look at the integration of gender-affirming care. You know that we go by Dr. Sebelius's model, gender affirmation is really important, and HIV prevention, co-locating those together, does that impact people's engagement with PrEP? We thought so. Dr. Sebelius led an article telling us that was the case. It's critical. The intervention itself involves PrEP and STI screening. Not a surprise, that's under the standard of care, right? We offer people either the big pill or the small pill, Truvada or Descovy. You can say brand names here, right? And then STI screening and treatment. And then the additional intervention was gender-affirming hormones and peer health navigation. So what does that mean? Part of affirming gender for many transgender people, I think most studies of 70 to 80% of transgender people desire physical changes to align their bodies with their gender identity, right? And that's incredibly important for their mental health and their sense of well-being, right? So providing that care was part of the gender-affirming intervention. The second part of the gender-affirming intervention was peer health navigation. So another transgender person, these are all trans women, so another trans woman who can help that person navigate health systems and overcome some of those social barriers. So you're having trouble with housing, right? As a peer health navigator, how can I connect you to resources around housing? So you're having trouble finding a job. As a peer health navigator, how can I help you find the resources for a job? How can I help you find a community of support if you're feeling isolated? Those kinds of things. We have structured sessions. I can tell you now, we've talked to the peer navigators. You know, you design an intervention and then people do what they do. So I don't know how structured these interventions were. But there was the structured sessions were really designed to be skill building for the person. So it's not just like I can connect to things, but how can we build your skills so that once this is over, you can help yourself identify and find the things that you need. Our goal was to look at the accessibility and feasibility of this integrated strategy and to see if it affected uptake, adherence, and persistence on PrEP. We enrolled 310 trans women. The goal was to randomly assign them to either the intervention arm or the not intervention arm. What we ended up doing was that the intervention arm got the entire intervention for the whole 18 months. Then there was a deferred arm that got standard of care, which was just the PrEP and STI screening and referral out for any other services. And then at 6 months, they were offered the combined intervention. Good. We had 5 sites, 1 in Brazil, 4 in the US. We tried to make it as community engaged as possible. So the other protocol chair, Barry Reisner, is a transgender man, openly transgender man, not like telling all the business. We used an evidence-informed peer-led intervention, and we tried to be responsive to community consultation. So what we did is we took the draft protocol and we went to each of the sites and met with trans people in the community. We're usually anywhere from 10 to, one site had the result was like 30 people there, and said, hey, this is what we're planning on doing, this is what we think, what do you think, how should we change things, what's going on? How do you feel about this study? And we got lots of really great feedback. And then we had to fight with the scientific chairs to get it done. So the initial design was a randomized control trial, right? So like pinnacle of scientific evidence. And when we went to the community, we said, there's no way that you're gonna have anybody who wants to be denied a service that you're offering. Even though you're saying there's no evidence to show that this works, for us, it feels like it's clear that this is gonna be better. And we don't think that it's fair to randomize. So that's how we moved to the immediate versus deferred arm. So that nobody was being denied, and people were being delayed, but nobody was going to be denied. And that required us then to extend the follow-up for 18 months so that everybody got at least a year of the combined intervention. You good? That was the biggest fight. So we had to go back to the leadership who controls the purse strings and say, the community's said no to this randomized controlled trial.
Right. So how do you handle like from maybe the self-seeking prep when you want to do like a follow-up session?
Yeah, we just track it. Yeah, because what we're trying to see is if it actually didn't make a difference, then it didn't make a difference. Right? So we can't force them to take it. We were offering it to everybody. It was very interesting though. We have some preliminary data that I posted last year with you because we're presenting it at a conference in October. But I can tell you on the low, like some of the interesting things that we found. Let's go there. The study visits were every 3 months. At those visits, they got refills on their PrEP and their gender-affirming hormone therapy, lab tests, took a survey. Our primary outcome was biological adherence, so we were measuring tenofovir levels since everybody was getting the pill. The shots weren't available when we started the study. And their survey responses around their sexual behavior. I thought it was really important to do a qualitative sub-study. We haven't put in the analysis for that yet, but we really wanted to understand from people, one, why are you in the study? Two, what are your decision-making thoughts around taking PrEP? How do you decide whether PrEP is something you want or not? How do you decide to go on it? How do you decide to go off of it? What do you think your chances are of acquiring HIV? Is that related to your decisions around PrEP? Those kinds of things. And then a drug interaction sub-study, because there were some concerns in the community that maybe people weren't taking their PrEP because they were worried about it interfering with the hormones that they were taking for gender affirmation, right? So we wanted to get some evidence, like we didn't think that was true based on some other small studies, but let's get the evidence. So that's what we are doing. Right now, we completed enrollment, baseline enrollment in December 2022. We were able to reach 99% of our enrollment target. That might not seem like a big deal to you all, but people were literally unconvinced that we could enroll 310 transgender women, but we did. Retention remains high, I think over 80% at all of the sites. We expect the last study visit to be no later than September. We are doing a preliminary analysis of the first 26 weeks. Obviously, we finished that for all of the participants, and the abstract was accepted to our review. So if you promise not to tell anybody, I'll tell you what we found.
I was recorded.
Okay, never mind. I can tell you about it. I will say this, that one of the data points that we added was focus groups with the peer navigators. So there were 5 sites and 8 peer navigators. And we asked them, so did you follow the protocol? What do you think the answer was? No. They're like, these are my sisters, they have needs, I'm doing what they need. I don't care what arm they're in, right? We're gonna support what they need, which is what community activists and peer navigators do. So that might have had an influence on the outcome. Done with that. Any questions about that study other than the thing I can't tell you because we're being recorded? Thank you for that.
No worries.
Trouble with the HPT, and that'd be very bad. All right. So the next thing I'm going to talk about is related to that physiological impact of stress. It's called Light Plus. The technical name for the NIH who's funding this is the biopsychosocial mechanism linking gender minority stress to HIV comorbidities. How is that for explaining long names that nobody wants? So we can't be like enrolled in the biopsychosocial mechanism study, so it's the light. It's over. Why do we do this? The study is with Black and Latino transgender women living with HIV. So it's not a prevention study, it's a outcome study for people who have HIV. What do we know? We know that cardiovascular disease is higher among transgender women than it is among cisgender women. We know that in addition to higher rates of traditional risk factors like smoking and obesity and those kinds of things, that trans women are more likely to be living with HIV. We know that HIV actually increases cardiovascular disease risk. We know that they have a lot of psychosocial stressors, which I have already beaten that forward to death. And we know that in a lot of studies, there's evidence that exogenous estrogens, so the kinds of hormone therapy that transgender women take, can increase your risk for heart disease, right? So multiple factors that increase your risk for heart right? So that was the context of the study. But we thought, maybe that's not the whole story, right? Maybe it's not like hormones, not the whole story. So we were looking at, what about people, this is a minority stress theory made super complicated. I will simplify as best I can. This is intended to depict, let's use this little pointer here. This is intended to depict all the different kinds of stressors experienced by transgender women living with HIV, the people we enrolled in our study. Black and Latina transgender women living with HIV experience all these kinds of stigmas. They also experience the regular stigma or stressors that we all experience, like, oh, rent's too high, groceries are too expensive, I missed a bus, I'm going to be late to work, all of those things. But they also experience stressors related to all this stigma, so prejudice, discrimination, and violence. That leads to expecting to be rejected, trying to hide parts of your identity that are not acceptable to other people, internalized homophobia and transphobia, because often those things come together. But it also means that they have specific coping strategies, often community support, social support, and access to resources that marginalized communities often tap into. And I think it's important to remember that exists as well. But what we were interested in, you can even have, yes, we were interested in what happens over here. So we know all those stressors. We know that those stressors lead to physical and mental health negative outcomes. How does it do that? And part of it is through that physiologic dysregulation to our immune and neuroendocrine system that happens from chronic stress. It's been studied most often in like physical stress, like if you have a burn over half of your body, you have the same sort of dysregulation, right? Because it's a physical stressor. But psychosocial stressors have a similar impact.
Sorry, question.
Yeah.
What is the allosteric load? Is that different from allostatic load?
It's the same thing, but they use different terms depending on what country but yeah.
Okay.
Yeah, so I guess I should say that. So allostatic load is basically the term that's used for the wear and tear, the chronic wear and tear on the body. People might have heard it called weathering. Some people study it related to race. It's that physiological dysregulation that comes from chronic stress. So we were interested in this study in looking at, okay, we know trans women have all of these stigmas related to living with HIV, Black, Latina, identities, racism, and ethnocentrism, and all that stuff. And here's the chronic stress. And here's heart disease as the outcome. Because there's been a lot of study on chronic stress and heart disease, not among transgender women and not among people with HIV, but there has been that. What role does gender-affirming hormone therapy play? Is it making things worse or not? Or is it the stress that's making things worse? Let's see. So what I'm going to present to you is some results from the baseline survey. So we did a lot of things. We asked people to collect salivary cortisol. So I don't know if anybody's ever done that, but I had to do it at state camp. So it's start at the beginning. So your HCA axis produces cortisol. You can measure it in your saliva. There is a normal curve that's supposed to happen where you wake up in the morning and before you get out of bed, your cortisol is kind of at a stable level. And then the process of waking up is a little stressful on the body, right? So it goes up, right, within the first 30 minutes. And then over the course of the day, it falls down as your body gets used to being alive. So the curve looks like this, right? For people who are exposed to a lot of chronic stress, that curve actually gets blunted. So the stress you wake up with and the stress you have 30 minutes later is about the same. You know, it doesn't go like this, it goes like this. And then it doesn't go down over the course of the day, it kind of stays high. So both of those kinds of responses are stress, chronic stress, dysregulation response. We also measured allostatic load through blood work and some other work. For this analysis, where we're looking at cardiovascular diseases, our outcomes, we measured how long people were taking gender-affirming hormone therapy, estrogen, because that's thought to be a driver of cardiovascular disease risk. And we found that in the 5-area analysis. And then we looked at how perceived stress, hey, I feel stressed out, like, is that related? And then allostatic load. I'm not going to share the cortisol results here. It will take us the rest of the day just to explain what they mean. But allostatic load, the higher the number, the greater the physiologic dysregulation. These are our results. When we looked at our first model that looked at perceived stress, and these are the other variables that we looked at. We controlled for or adjusted for income, education, and age. Obviously, the older you get, but the more dysregulated your body gets anyway, right? Also, the older you get, the higher your risk of heart disease. The older you get, obviously, the longer time you've had to take hormones. So obviously, as a confounder, we wanted to control for that, and it was significant in all of the models. We also controlled for income and education because we know those are also related to cardiovascular disease. The things we're interested in looking at were allostatic load and perceived stress, and we wanted to look at the interaction term. So does the relationship between taking hormones and having a cardiovascular disease change based on the level of stress somebody's experiencing? That question makes sense. So, my favorite picture in the world is the one on the far right. So that is the one that's looking at allostatic load, right? So what we did for that picture is, can I walk you through this picture? Okay, so you can see this is allostatic load. The lowest levels of allostatic load are red. That means people with the lowest level of chronic stress. Blue, people with the highest level of chronic stress. Cardiovascular disease risk, with higher being greater risk. Length of time on hormones, more hormone exposure on the bottom, right? You can see for people with low levels of stress, there wasn't a higher risk of cardiovascular disease with higher amounts of hormones. In fact, you can see that goes down a little bit, right? So if you have low stress, taking hormones doesn't make your heart disease risk go up. But if you have high stress, you can see there's a positive relationship. The longer the hormone exposure, the greater the cardiovascular disease. Does that make sense? I submitted this paper yesterday. I'm super excited. So not only is allostatic load significantly related to cardiovascular disease in the model by itself, but if we look at the extremes, potentially a stressful effect, we see like no overlap in the confidence interval, and we see a very big difference. So maybe we shouldn't just be looking at the hormone, but we should be looking at what is the social circumstances, the psychosocial circumstances in which people are living that affects their body, that makes a difference in how they even process this medication and how it affects their health outcomes. And that's why I should do all this referencing first. So we concluded, things I just said, it was significantly associated with cardiovascular disease risk, longer duration of hormone therapy increased risk only among those with the highest allostatic load. So some of the changes that increase cardiovascular disease risk among transgender women on hormone therapy may be due to stress rather than hormone therapy itself. We need more research on cardiovascular disease risk factors that could go beyond just hormone therapy. And this might not be relevant to all of you, but if you are all a bunch of primary care providers, primary care doctors, or practitioners, PAs, and you said, what is the biggest risk factor of heart disease among transgender women? You'd be like, hormones. And so our goal is to say it's really more complicated than that. Reducing chronic stress may be an important way to reduce cardiovascular disease. So it's 11 o'clock, so that means I'm not going to show you the last study. we do have. Do you have time? Do you want to stay for 5 more minutes?
Yeah.
Okay. That was my baby. This other one I'm also not going to have time for, but it's the international study that I want to tell you about. It's Jugulu Uzabone, which was named by the community advisory board. It means be happy and be yourself. Good. Yeah.
This one? Methodology. So we use the slide before this one. So we use the multiple linear regression model.
Yes.
Just like, why do you choose MLR in the first? Because you had follow-up sessions when you introduce the intervention. Is there a particular reason why you chose MLR as your methodology for?
Yes, I have 2 answers for you. One is that this is only baseline data. So we're still cleaning the 12 months and the 24 months data. We just finished collecting data last month. So this is all baseline. And then the second reason is that's what the statistician said. Do you have a suggestion of a better model?
Well, currently, my internship research is an intervention as well.
Mm-hmm.
So we're trying to consider the significance of the intervention for compared to the standard of care.
Mm-hmm.
Right. So it's actually a mental health intervention, and
Mm-hmm.
it's also a longitudinal study, and we have follow-up sessions, from 4 follow-up sessions. So we're using GEE model and mixed effect model, right?
That's what we're going to use when we use the thank you for mentioning that. When we do the longitudinal one.
Yeah.
That is the plan, yeah. So this was, they're all continuous outcomes.
Yes.
That's the baseline. You're paying attention, I know that. Other questions or comments about this one? All right, we'll move on. So, background on this. This is South Africa. U.S. Agency for International Development funded 4 transgender-specific clinics throughout the country in 4 different regions: Johannesburg, Cape Town, Nelson Mandela Bay, and Buffalo City. USAID funds programs, but not research. So they're like, well, we have these programs, but we don't have any way of knowing if they work. So once the USAID funding is gone, how are we going to tell the government whether it's worth investing in this or not? And so that's where we came along and are doing an implementation science study with them. What's different about these clinics compared to the public health clinics? Some of them are standalone, some of them are co-located with the public health clinics, but they provide gender-affirming hormone therapy, which is not available in the public health sector without going to a tertiary care site, just like there's primary care, and then there's secondary care, and then there's tertiary care. It's really hard to get, right? But here, these primary care centers provide gender-affirming hormone therapy. They also provide ancillary services like psychosocial support, referral for post-violence care. Gender-based violence is very high. Legal support, substance use services, and they also have partnerships with the local community. So the community helps decide what kind of services should be provided at these sites, and they have a board who helps guide the services at that site in general. So they did community engagement outreach, and then they have a board that they meet with regularly to say this is what's happening at our clinic, to get feedback on how services should be implemented. I'm going to skip these, I'm sorry. Don't hate me. That was all to show you that these are those are the descriptions of who's at the site so far, but I want to talk about the study, and I am supposed to leave. So, it's an implementation science study, and I think it's like a type 2 effort. So we're looking at efficacy as well as implementation. We want to understand what are the barriers to getting this kind of clinic started, what was required to get them started, did they need champions, like what was needed, what are the resources? Did the community really find it acceptable? Are they using it? Is it feasible to really scale this up in other places? Then we wanted to see how effective it was. We were looking at 2 outcomes. For the people living with HIV who got their care there, how well did they achieve viral suppression? And the second is for people who are not living with HIV, we had a lot of conversation about whether it should be PrEP adherent. And then we talked about, like, a lot of it depends on whether somebody actually needs PrEP or not, right? So we changed it to PrEP effective adherent, meaning for people who could benefit from PrEP and were prescribed PrEP, were they adherent to it? And for people who are not on PrEP, were they either not having sex or using condoms when they have sex? So that was our combined outcome. And our last thing is, what do governments care about? Money, right? So what was the cost? What is the additional cost of delivering services in this way compared to the general way? So SSD is standard service delivery, TGDSD is transgender differentiated service delivery. So those are our main questions. We are planning and enrolling about 600 people, 400 living with HIV, 200 who are not living with HIV, divided half between differentiated service delivery sites and half between the standard sites. And we're collecting a whole bunch of data. We're doing surveys every 3 months. We're doing labs at baseline and follow-up to viral level. And because I'm dean, we're doing qualitative interviews with both the people who work at the site to understand their experience and the people who get their care at the site. And we're also doing, what am I missing? I think that's everything. Oh, and collecting costs. So there's a whole costing center who's a partner on this that's collecting like They literally go to the site and they're like, how many exam tables, how many rooms, how many of these kits do you use for all of the sites, so they can get the exact cost, and share that with the government in terms of that. So as of last week, they're doing great. They've enrolled almost everybody. I think the enrollment is like over 500 people. We had divided it between NGC people living with HIV, people who are not, 4 different sites. They surpassed their targets for everybody except the standard sites and people living with HIV. So we're still enrolling that group of people. We've also got 20 of the in-depth interviews already collected, 23 of the key informant interviews. The person who's the project manager for this is like amazing. We started collecting data in like January. This is where we are. So they're doing a fantastic job. We think we'll finish enrollment next month, which starts tomorrow, and then finish with the follow-ups at the end of July. So I have no data, but just excitement about that. We did submit an abstract. This is described as baseline sample that's going to be presented at the World Professional Association Transgender Health Conference, which is going to be in September. So invite you back. But that's it. Thank you so much. I said discuss, but we discussed during. I'm so happy to answer any questions. I have like 5 more minutes before I have to run. Feedback, is there stuff like, I didn't need to hear all that, or that was too much, or I need more?
I had a little bit of feedback about one of your point estimates, the months in hormones. I didn't know if like a 1 month was like clinically meaningful, but you can scale it to get a better interpretation. It was like 1 point, the ratio was like 1.000.
Yeah, it was terrible. Yeah. So when I reported it in the paper, yeah, I multiplied by 12.
Okay.
Yeah, we did it months because that's how we collected the data, because we didn't want, for people who've been on hormones for less than a year, we didn't want to like exclude them, so we did it by month. Yeah, but yeah, point taken. Yeah, this is like nothing matters.
I was just gonna say that we've had like a lot of different talks this summer, and this is really good because I think it's different than a lot of the talks we've had.
Is that okay? Because I'm not really sure what to talk about.
We've been hearing, a lot about like disparities in HIV, but haven't heard about transgender people and disparities. And we also the primer on the link is also really good. Everyone, even if they've heard that before, can have a reminder of the different technology. And I was actually messaging Tina a couple of weeks ago because I was working on a paper and I didn't agree with their use of gender in the paper. I was like, it should be sex, and there was some back and forth. And I was like, am I crazy? I feel like I'm doing this right, but like people are pushing back on me, so it's always good, in any research, you have to be really mindful of the terminology you're using.
So point well taken, and it is an area of active conversation. I was super excited. I was invited to Germany last year, where there was a whole 1-week forum talking about the entanglement of sex and gender from legal, policy, biology, social science, all like people from all different disciplines in the room, and it was like different planets trying to have a conversation, because I think it depends on your discipline is how you think about those words working. And then I think it's re-recorded, but NIH had it was a 2-day forum on sex and gender where they had experts come and talk about a wide variety of things related to those terms and what they mean and how they're operationalized in different kinds of settings. So I think the fact that you have this conversation is actually a beautiful thing, because I think the most important thing is their communication. That's what everybody's speaking to make sure they're doing. Yeah. It's an exciting time.
Are you okay to share the slides or no?
Yeah, I think so. I don't think I have anything that I'm not supposed to share on there. So if somebody reminds me, I will send them. If you don't remind me, I may remember this. I'll send them to you.
Yeah.
Yes, if you want to email me, I'll send them. Yeah.
All right. Yeah. Thank you so much again.
Thank you.